Hey everyone. Okay, so we'll get started now with the Jousse Lecture. So I'm Damien Manzo, and I'm a postdoctoral fellow here at KITE, and I'm one of the hosts of the Jousse Lecture. So today we'll have a great talk, well, presumably great talk by Dr. Julio Furlan, and he's a staff neurologist and clinician investigator in the Division of Physical Medicine and Rehab and the Spinal Cord Injury Rehab Program at Lyndhurst Center, Toronto Rehab, UHN. He's a consultant neurologist at Ultimate Health, UHN, and a senior scientist at KITE. And he's also associate professor in the Department of Medicine at the University of Toronto. And his research is focused on, as we'll see today, outcome measures and predictors of outcomes of individuals living with spinal cord injury or degenerative cervical myelopathy, and neuromodulation therapies for management of individuals living with spinal cord injury or degenerative cervical myelopathy. And just a reminder that if you can't catch the whole lecture, it's going to be recorded and posted on the KITE website and KITE YouTube. Okay, so Julio will share his screen and we'll get started.
Good afternoon, everyone, and thank you, Daniel, for introduction. Let's see if I can share my screen. Here. So the purpose of today is, the purpose of the talk today is highlight some of the key points about the degenerative cervical myelopathy. And I call that common things are common just because you're going to see what are the importance of the topic. And if you know about it, maybe refreshing a few ideas in terms of the updates on DCM, but also if you're not familiarized, maybe you can now understand why you need to know about this disease. So So just to disclose, I don't have any commercial interest in this talk, and it's not related to what we're talking today. So I thought it was going to be a good idea to maybe bring a case, and with the case, we can highlight a few aspects of what the talk is going to be highlighting as well. So 69-year-old woman was referred for increase in neuropathic pain in the lower extremities a few months before she saw me. And that was in the context of 2 prior lumbosacral spine surgeries for degenerative disc disease of the lumbar and the lower thoracic spine. She had a very complex previous medical history, but I just want to highlight that she had a prior diagnosis of bilateral carpal tunnel syndrome and got a surgical release 5 and 6 years before I saw her. When I was seeing her for the first year, she started complaining about this slowly progressive loss of dexterity in both hands, more on the left, that was initially attributed outside by a colleague that has bilateral CTS causing that symptom. And I did a DMG, never contact studies, and in matter of fact, the patient actually had a bilateral, relatively mild median neuropathy at the wrist. Remember, this case was a case after surgery for at least 5 years. And the question now is, what should we do? Just expect that it is a carpal tunnel syndrome progressing, wasn't completely released, is related to the polyneuropathy that eventually the patient was diagnosed with as a cause of neuropathic pain. So I just want to highlight a few things that we need to know about this. So the question is this only something that you would expect, or you need to be actually aware of other possible causes for the loss of dexterity over time, not attributing only to the bilateral CTS that could be progress, even though, again, was surgically treated. So as the team is soccer for this month, so a yellow flag for a few things in the history that are important. So it's a mild neuropathy at the wrist based on the updated information from nerve conduction stats. And the patient had a release of the carpal tunnel in both sides not long ago. The other thing is, obviously, degenerative disc disease is her profile. So you need to always remember, if somebody has degenerative disease in one segment of the spine, chances are that may develop in other areas as well. So that sets the case to know what that is. So what I did was I did MRI of the cervical spine, and you can see here how it looks like. So this is a T2 weighted signal MRI in the sagittal view. And what I want to highlight is you can see in the middle some areas where there is a little bit of loss of the space in the spinal canal, but still relatively good considering the fact that she's 69 and the only complaint that she has, again, is loss of dexterity. Now, 2 years later, as we would typically do a follow-up on these patients, she's getting worse, and look at the image here, how worse is comparative to the initial one. So 2 years apart, and basically you can see what I'm highlighting here. So there is more stenosis, more narrow canal of the spinal canal, and also you see it's a multi-level. So there has been a significant progression in terms of the MR images in the context of still a complaint of progressively getting worse, the loss of dexterity, so fine movements in the hands. So for you to have an idea how significant that compression is, I just put it for you 2 images. One is in the level where you would expect to be normal. So you see in the sagittal view, you see the blue line, which actually shows where you're bisecting, and on the right side, you can see the axial view of the spinal cord, and let me focus on this area. So this one, you see the middle portion. I can set the middle portion here is the spinal cord, the spinal fluid all around, and you actually see nicely the nerve roots coming out as well. So that's a beautiful one. Nothing abnormal on this. Now let's go when the actually compression is significant, and let's see how that represents in terms of the imaging. Here you don't see anymore the CSF around. The nerves are being squeezed bilaterally, impinging more on the right than the left. And you see the spinal cord has been actually compressed. So there has been a significant progression of that stenosis from the beginning when I was seeing 2 years before. So in this case, obviously, the patient was recommended to go to a neurosurgeon who did a spinal cord compression of the cervical spine, and she maintained the symptoms after the surgery. So did not progress. And we're going to see what is important as information as we go through the talk. So I just want to bring this case to let you know. Sometimes, common things are common. So carpal tunnel syndrome is very common. Polyneuropathy is very common, relatively common. But also we need to think about the degenerative cervical myelopathy, which I hope I can show you how common it is as well. Okay. So the outline of the talk will be give us some information about epidemiology, pathophysiology, diagnosis, management of the more severe cases called moderate to severe, and the mild cases, and then give you some idea for you about this international initiative called the RECODE-DCM project. So starting from the epidemiology, I just want to highlight this term, degenerative cervical myelopathy, because you may actually try to search. You're not seeing this a long time ago, because it was in this international panel which decided to call degenerative cervical myelopathy as an overarching term for different pathologies that I may have heard before, such as cervical spondylotic myelopathy, cervical stenosis, degenerative disc disease of the cervical spine, and on. But this is more comprehensive, but also composed of many pathologies that would be in the limbo if you don't actually have a more overarching term as it is in here. And if you look at some of the data in Canada based on the Rick Hansen spinal cord injury registry, they did a sampling of the cases for, I guess, 1 year in terms of the non-traumatic spinal cord injury. You can appreciate on the left the degenerative for either under 65 years of age or older than 65 years of age. It is still the most prevalent cause, is degenerative causes, and most of it is actually what we call degenerative cervical myelopathy. Okay? So it's quite prevalent. And in overall, what we typically say to patients is the incidence increases with age. Above 50 years of age, at least 2.4% of the adults would have some degree of degenerative cervical myelopathy, either seen by the MRI, or sometimes even some subtle but still present symptoms. So it's quite prevalent. Always remember this. But now, how we can understand this as a pathology that developed over time, we don't actually know quite fully how that develops, but we know some factors are important. So we know there are static factors and there are dynamic factors. The static factors are the ones that could be either congenital or secondary to intravertebral disc degeneration and spondylosis, which means either one would narrow the canal for the spinal cord, where the spinal cord sits on, and that then causes that static manifestation of spinal stenosis. When this is in the upright position is one thing, but when you actually extend or flex, you can appreciate in the diagram that you actually can have more compression, and that's what causes over time movements of the neck, more damage of the spinal cord in the cervical level, and cause progression of the symptoms as well. Not saying, though, that a person with this problem may have more difficulty to walk, higher risk for falls, and a fall can cause a acute traumatic spinal cord injury more prevalent than a person without degenerative cervical myelopathy, because you can appreciate that spinal canal is quite stenotic, narrow canal. So any movement of the abrupt movement of the spine, either hyperflexion or hyperextension, would cause a bruise in the spinal cord, which is spinal cord injury. Okay. More things that we know based on the histopathology. We know there is demyelination, gliosis, cavitation, there is white matter degeneration, descent and descent tracts have degeneration. And we basically say that all these processes is due to ischemia, a bloody spinal cord barrier disruption. There is a process for chronic inflammation that can also trigger apoptosis, and that's overall the way that we see this as a pathology that typically progresses over time. Now, in terms of the diagnosis, the case that I showed you was the reverse, because the patient came in with one problem to me and then became a diagnosis afterwards. But many times it comes with a set of symptoms. I'm going to give you just some of ideas of the symptoms. Then you need to actually dig it out from the history and also do a proper neurologic examination. That you can appreciate now upper motor neuron signs and lower motor neuron signs, meaning the upper motor neuron signs are in the lower extremities and can mix with the upper extremity, and the upper extremity you typically see lower motor neuron signs. That means lower motor neuron signs means flaccidity, weakness, loss of the reflexes, and on. And you can see sometimes fasciculations. The upper motor neuron signs is when you have spasticity and you have hyperreflexia, and you don't lose the muscle bulk in those cases. Okay. One thing is always when you have that clinical suspicions is the primary diagnostic tool is MRI. Here is listed the CT, plain X-ray. That's basically not really important at all. We go straight to MRI because you need to see properly the spinal cord as well as the structure in the spine. Now, if you want to hear more in terms of the symptoms and signs, how they actually are reported by the patients, is quite variable. And in this survey that was put together in this paper is open access. You can read more what we did together as a group in terms of reporting those common signs and symptoms when diagnosing people with degenerative cervical myelopathy. The other things to recognize, as the case that I show you, is there are quite a few mimickers of the symptoms for DCM that you need to know. Otherwise, either you do a wrong diagnosis or you miss another diagnosis. So things like are even written here, carpal tunnel syndrome. So I have a handful of cases like this, basically referred to me as a recurrent carpal tunnel syndrome. And when I do the EMG and every contraction studies to do a reoperation. And the cases were actually DCM. So completely missed on the case. But there are many other things like polyneuropathy. You can see there is ALS and many other causes. Some of them are listed here. So we have this lower motor neuron signs, upper motor neuron signs, a combination of them. And you can appreciate how variable can be what we call differential diagnosis for this pathology. Okay. Now, when you go to the treatment time, I just want to make a highlight on one thing is we graded them based on a scale called the modified GOA, Japanese Orthopedic Association score, as you can see. But I want to jump into the MGOA. I can explain a little bit more about this because everything else that we talked about in terms of treatment is going to be based on that scale. So when I was doing my postdoc here, I had the privilege to work with Dr. Craven in this paper. We actually did a psychometric property analysis of all available modified GOA scores as would be reported in the literature and see they actually are very different. So the original one was obviously developed in Japan, but because they would use the sticks to eat, would not make sense in the Western countries to be as one of the items in their questionnaire. So they started developing using utensils, and many of them were actually, you can see here, at least 4 of them were already in publishing in the literature, and there was another one that was modified by Lee in 2015, as well as expanding more of the scale. So there are quite a variety of what is called MGOA. So you need to be careful when if you read this to see which one is actually the one that they use, because they can be very different in the actually scores. And what we found is basically that the MGOA that was originally developed by Benzo and colleagues in 1991 was the one that had more of the information about psychometric properties, meaning it's quite reliable, validated, and responsive too. So we just said, this is probably, if you're going to use any one of them, probably the best one to use since it has been more studied and proven to be validated. That's the way that it looks like in the GOA from Benzo in 1991. You can see there are evaluations of motor dysfunction, sensory dysfunction, and includes a sphincter dysfunction for the bladder. And there is a scale that goes from for upper extremities, lower extremities, and in the motor, and for the upper extremities in the sensory. And then you score 18, you are normal. Below this is abnormal, and there is a grading, and you can see mild, moderate, and severe, as you can see on the right side. And basically, what we want to highlight in terms of the treatment and management of these patients is the group of moderate to severe. That's quite different than what we do for the mild DCM. What that means? Means when you have this group, we know that they are already committed to have surgery. So a person that has comes with a moderate to severe DCM, there is no other question but going to surgery. And that's basically what we see in the literature. And this is the clinical practice guidelines that was developed here in Toronto. It was an international panel led by Dr. Michael Fennis from Toronto Western Hospital. And in 2017 was the first clinical practice guidelines on DCM that was developed. And the recommendations came in as for mild, moderate, and severe DCM, and even the non-myelopathic cases with evidence of cord compression in the imaging. So again, this is a case of moderate to severe. No question, the recommendation is surgical intervention. The only question now is clinically stable to go to intervention or not? And if not, then we need to see later on what to do with these patients. But the primary treatment is always surgical treatment for this group of patients. What was interesting to see in this study that I did when I did my fellowship at the Toronto Western Hospital, but later on many other studies came up to show that what we typically say to patients with a moderate to severe DCM is the expectation is the surgery will reduce the risk of deterioration, meaning neurological worsening of your symptoms. In matter of fact, we can see now, even in this graphic, that in different scales that we use here, so the Neuric grade scale, which is a grade scale for the disability, the impairment related to DCM, the modified GOA, and also the Berg balancing scale, which is for balancing, you can see that before the surgery, they had a higher score. They had a higher score in the Neuric, and then decrease as went from 6 months to 1 year. So there was an improvement with surgery. The MGOA increased as would expect to get better over time. Again, within 1 year, there has been improving the group. And even the balance score improved as well. So nowadays, even though you will say to the patients, the primary goal of the surgery is to avoid the neurological deterioration of the disease, we need to remember that they may actually get better. It's not only a matter of saving them to get worse. Okay. Now, obviously, with surgical treatment, there is always a risk. And what outweighs this balance, the benefits and risks is something that needs obviously to be wise to do. But in this case, most of them, they are surgically treatable. And if they agree, would be taken to operating room. And you can see here in this series of 81 cases of DCM, 18.5% they had some degree of complications, either medical or surgical. And many of them are conservatively treated, they don't get worse, and they actually get better over time. So it's not something that you typically see patients being disabled after the surgery when they are much better before. So typically you don't see that as a high risk. And depends obviously the experience of the surgeon and also the resources available for the surgical treatment. Other things that we also look at are the factors associated with poor neurological and functional recovery. And you can see here highlighted what that would be. So older age would be a factor. So comorbidities, that's CCC means Charleston Comorbidity Index, even the number of ICD codes we use. And obviously, if a patient had a post-op complication, depends on the degree, that could affect their recovery after the surgery as well. Now, what you don't see here is if there is any marker beyond what we know on this table, that's typically collected the data from patients, if there is any other marker that you can predict outcomes. So is neuroimaging actually something that you can use? And you had this question before as well. And we looked into the preoperative and postoperative MRI to see if there is anything that you can find in MRIs that could tell us the story about the risks for getting better after the surgery or getting worse. So when we did this is a busy table. I'm sorry for that. You have in the left side here, you have the MGOA, Neuric scale, which are very specific for DCM. Then you have a grip function and then a walking and Berg balance test. And you see on the middle here on the top, you see what are the variations of the changes in the spinal cord that we saw in this study. So one of them is, if you look in terms of this low T1 signal change, if that's present, actually can negatively affect the results of these individuals. Now, if there is a more focal and versus diffuse signal change, that also can be a factor on the prognosis of these individuals. And lastly, if you look at the segmentation of the T2 signal change, that also relates to more the walking and the balance, which means affects more the lower extremities. So there are some factors, if you look at the image before the surgery, that you can already sense that maybe this case will not get much better after the surgery. Hopefully, it will reduce the risk of the neurological deterioration. So that's the pre-op. The post-op now, right after having the surgery, what we did is a different measurement of the canal. And you see, for example, this is measurement in the site of a more narrow canal. That you measure that at that distance and in the spinal, which is the diameter of the spinal cord. And then you actually divide this number by the average between two segments above and two segments below of the same measurement. And what we found in the post-op MRI is actually similar to what we found in the pre-op. So if there is a persistent T2 signal change, that's something that we know is going to interfere negatively with the outcome of these patients. And also if there is a persistent canal stenosis even after the surgery. So that tells us, obviously, this case, you will not get much better or maybe even deteriorate in the future. Okay? So I think it gives a sense. We didn't go much more along this because imaging is always something that we use, but it's very hard to make a score to establish quite well changes based on this kind of MRI, which is the routine MRI. And I know some colleagues are using different DTI, MRIs, tachography, and trying to evaluate if the other parameters could be more reliable and more clinically relevant for that matter. So this is easy because moderate to severe, I told you, surgical treatment. And now, what do we do with patients that have mild DCM or no myelopathic patients with cervical compression on the MRI? And that's a group that actually we are more concerned about because they're the ones typically when they find out, they go to the surgeon, they do the surgery, and they have the treatment. The other ones, typically when we see that image that I showed, the case that I present to you, many colleagues would say, yeah, it's not the cervical spine, it's not that significant, and just abandon the idea of that could be progressing. And that's something that we know that's a mistake. Okay, so we don't do this. We need to continue seeing these patients longitudinally because then we know that they may deteriorate clinically, radiographically, or both. Okay. So this is what I was suggesting initially. So if you have somebody who has a non-operative management initially, we just recommend a conservative treatment but follow-up And this case that I show here is a case that we put together a book. Dr. Furlan is the editor, and I wrote the chapter 18, which is non-operative treatment. And this figure is there because I just found it interesting that I saw this patient with 11 years follow-up of imaging, not much symptoms at all. And you can see that even 11 years after, even though there is a mild degenerative cervical myelopathy, did not progress. So you need to follow up because that can be this case or the case that initially showed you before the presentation started. Now, there are the cases that are non-myelopathic patients, but there is still evidence of the cervical cord compression without signs or symptoms of radiculopathy. In this case, we don't recommend surgery initially, but you need to, again, follow up on them regularly. And the ones that actually have a electrophysiological confirmation of a radiculopathy, that's the case that you need to start thinking about surgical treatment. If there is none, depends on the symptoms, you can still counsel for conservative management. So I just put it together for you to have an idea what I would typically do in my clinic. So if I have a case with mild DCM or no myelopathic DCM, I follow this patient, I follow clinically, and in the beginning, I follow every 3 months clinically, MRI every year. As I see if the patient is not progressing, we can start to spread into 6 months in the second year, and then yearly follow-ups. And that's basically what we typically do in the clinic for this case. If the patient, obviously, as I showed you the first case, has a neurological deterioration, now you can change your management to consider surgical treatment. And this is basically on what we know from the disease, even though we know some things, but we don't know a lot of things about the disease. We don't know who you are seeing in front of you is going to go into what the curve shows you. So you can have people with mild DCM and have neurological deterioration 90% for the case in the first year. And you can read it on the side. It can be 16 at 2 years, 21% in 3 years, 27% in 5 years, up to 37% in 20 years. So the longer you actually follow these patients, higher chance to capture a neurological deterioration. But not everybody actually deteriorates. So what we now think is there are phenotypes of this disease, and these patients, we don't know still what the phenotypes are. And Dr. Jeffrey Wilson from before St. Michael's Hospital, he's working at Cervical Hospital, put it together a grant for this. So I hope he's going to come with some clarity on this, understand of the phenotypes based on the clinical impression initially associated with neuroimaging maybe, and gives a sense of who is who in this curve when you've seen at the beginning of the follow-up. And now we have a case like this. So this is a patient that came to me for assessment of, again, very typical case, one of the handful cases that I told you, bilateral carpal tunnel syndrome, surgical treatment before, getting worse. This patient had paraplegia, and fair enough, this patient actually had a DCM, but unfortunately, because of his clinical condition, he could not. Initially, he deferred to go to a surgeon, and then eventually he clinically was not stable sufficiently to go to a surgical treatment. So he never got a treatment. But you can see in 10 years how different the progression of the disease in the image here is related to the other one that I just showed you. So, and we don't know which one is which one when you see the patient. So it's very difficult sometimes to make that clinical call. In this case, what do we do with this patient? So would it be considered now a moderate DCM? Would it be recommended surgical treatment, but cannot go through surgical treatment? And that's important to know, because now we need to know what to do with this patient, but also what to do with the other ones that are patients that they do have a mild DCM or no myelopathic DCM with compression of the spinal cord in the MRI. So we have the non-operative management usually considered safe and feasible for the less severe forms of the disease. We don't know many things, like even in traumatic spinal cord injury, what is the role, we test the volume and timing of these rehabilitation and the treatments that you can offer for these patients. And also we take much of the information that we know in terms of the principles and techniques for rehabilitation of these patients based on the spinal cord injury literature that's from traumatic cause. So the bottom line is we try to maximize neurological and functional outcomes, and you want to mitigate secondary health conditions, which obviously are common in DCM as well as in traumatic cervical spinal injury. And you can see here just a highlight of what we found in the literature, which is really scarce. And that's about neck immobilization or bracing, manual therapy, and potential neuroprotective strategies. And I just want to go brief on this because I have seen patients with this, and I alert you to be aware of this and also understanding of what the literature says. So soft collars are the less troublemakers when people use, but they are really not a great idea because they don't provide restriction to the motion as the rigid collars do. And but the rigid collars has a purpose when you have somebody who has an unstable spine, or have a patient that went through spine stabilization and requires this for a period of time. The only problem is if you keep them within a soft collar, even though they feel comfortable, you can have even some problems with atrophy of the muscles of the neck, and we typically recommend not using, and the skin complications more related to the rigid ones. And there is no evidence that they work at all, so it's not recommended. Now, the other thing more troublesome, it starts with cervical traction. So with the good intention of releasing the pain, some people do maneuvers like the picture is showing here, and you can see that they may be safe. I would say even safer than the next one I'm going to show you, which I totally not recommend. And but you need to be careful because if the patient is not under control of what it has been doing, maybe too late when the traction occurs and cause the injury of the spinal cord. So I typically say, if it's my cervical spine, don't touch. I will do it movement, nobody touches. Okay? And again, there is in the literature nothing to support that cervical traction works. Okay? This is the problem that I see, and we have seen at the Lyndhurst Center since I'm here, at least 4 cases of complication I'm going to mention to you in the next slide. This is often what people say, well, I go to my healthcare professional, sometimes chiropractor, and they say, I'm going to do some adjustments of your realignment of your neck. And those are the maneuvers of thrust that you can see here on the picture when they do drastic change of position, sometimes traction or not. And the problem is the patient is not under control. And many times I have seen patients say, oh, it hurts so much in the first couple of days and then it gets better. So that tells me it's not going so well, the therapy at all. But unfortunately, many patients actually undergo. And there are complications associated with this. So you can see in this data from Manitoba, they put some of the information. So 1 in 10,000 treatment consultations immediately after these manipulations can have a serious adverse event. 2 in 10,000 treatment consultations up to 7 days after treatment, and 6 in 100,000 cervical spine manipulations can have those serious consequences. And what are we talking about? We're talking about something like serious as stroke, artery dissection causing stroke or bleeding, occlusion of the artery, hematoma, hemorrhage in the brain, the cerebellum, transient attack ischemics. And also, we're talking about something that I have another slide I didn't put it because it was going to be too busy, which is disc herniation. So in my training in Canada, since I got started working, since my training, I saw one young man with a stroke related to these manipulations of the neck, in emergency. I saw 2 cases with tetraplegia and 1 case with paraplegia. So my recommendation is always, again, I reinforce this, is do not recommend and really educate your patients to not go forward because it can be really risky. And again, there is no evidence that they actually work well. Okay. So what else we can do for these patients? So in terms of the potential neuroprotective strategies, we don't have anything that can be called a disease-modifying agent for this disease. We hope in the future we will have, and it's one of the priorities of the research in the international group that highlighted. But there has been a couple of trials, one small one with corticosteroids during surgical treatment, and one with riluzole, which is a large trial here in Toronto by Dr. Michael Furlan. So this is the trial with using intravenous dexamethasone versus saline, and actually you don't see any benefit at all between placebo and treatment group after 24 months after the surgery. So it's not really helping much. So it was abandoned. The other one was this, again, there was a large phase 3 trial using riluzole, which would be a neuroprotective agent, sodium channel blocker. And what they found overall is, unfortunately, was not much at all in terms of benefit at all, in terms of the main outcome measures like MGOA and New York Scale, NEDI, which stands for Neck Disability Index, and even the ones that are health-related quality of life. So nothing changing, even the motor and sensory did not change at all. There may be a trend towards the benefit of reducing pain after the surgery, after the treatment and surgery, because these cases were undergoing surgery and then relapse. And but actually the trial showed the negative. It was well designed, well carried out, but in matter of fact, it was not positive at all. Now, what else do? We manage secondary health conditions, and they typically see patients with neuropathic pain and neck pain, spasticity, neurogenic bladder, neurogenic bowel, even cardiovascular dysfunction, sexual dysfunction, and you have sleep disorders and depression and fatigue. Those are common things that we see in this group of patients. And to mitigate these secondary health conditions, you typically use what we use for patients with traumatic spinal cord injury, the PVA guidelines and our practice as well. So not much more than what we typically would do for patients with traumatic spinal cord injury. Now, I just want to highlight very briefly the last portion, which is this international initiative was called the RECODE-DCM, so Research Objectives and Common Data Elements for Degenerative Cervical Myelopathy. It was really an international group. It was led by Dr. Kotler and Dr. Davis in the UK, supported by the AO Spine and NIHR. And they put it together an international group. I was one of the members of the steering committee, as well as Dr. Kelsey Ryan and Dr. Michael Fallons, and see some faces are familiar in the community of spinal cord injury. And the group was very large because we actually intended to do a standard term definition. That was, we came with DCM as the overarching term that I mentioned in the beginning. The minimum data set to be collecting the researches and what are the priority research questions would be. And that was really a multi-stakeholder design because we had only a variety of the practitioners, healthcare professionals, and we have different disciplines from medicine to other healthcare professionals. And we have quite a number of people with lived experience with DCM. And it was a series of systematic reviews to see what the literature would bring to us in terms of the evidence and knowing what is really understood right now in the literature at the time. We talked about something 5 years ago. And then the most stakeholder consensus meetings to come with the ideas that I'm going to show you. So 429 people involved from 68 countries, 17 specialties together to come in with these two. And here's the list of the key priorities. So one is obviously we need to increase awareness among the healthcare professionals and the public. We need to know better the history of DCM. We even don't need a diagnostic criteria of DCM. And hopefully a publication is going to come in very soon from this group as well as we're trying to publish now. And we need to know more in terms of the assessment and monitoring for these patients with DCM, meaning the ones that they meant to you before being diagnosed with moderate to severe spinal degenerative cervical myelopathy. We need to know better about the biological basis or pathology of this disease. And what you can do for perioperative rehabilitation, you can do prehab for these patients. So it's something that we don't have, and it's still an open field for research and needed. We need novel therapies, and that comes with that idea of disease-modifying therapies as well, as neuroprotective disease therapies. And then we have the socioeconomic impact of DCM that's not quite well established. And one of the areas of my passion as practice and as scientist is neurophysiology and neuroimaging. And we need to come up with more ideas. And the individualized surgical treatment is also a priority. So here you have a work of this group put it together in the 10 research priorities for DCM. So with that, I hope I convince you that DCM is a common thing. So common things are common. Remember this, that we still have a lot of things to understand in terms of what the pathophysiology of DCM is. And surgical decompression of the spinal cord is a treatment of choice for moderate to severe DCM. I can't emphasize them more enough. And the ones that are not surgically treated, you need to follow up on them. You can't just let them go and you hope for the best. Because as you saw in the curves, many of them they can deteriorate, and in that particular study, up to 20 years, 37% would have neurological deterioration. So we don't want to have those cases having more severe symptoms and delay more treatment that can be helpful. And there are several knowledge gaps that for most of you that do research is an open field for you to consider doing research in this area, because it is really important. It's relatively easy in terms of recruitment because they are quite prevalent. It's quite prevalent disease, and it's really a need that you have to fulfill. Last thing that I want to say something that we are going to bring. I was hoping to come here and tell you that it's open, but we are going to open a clinic here. And I appreciate the support from Dr. Kath Craven, the medical lead from the hospital, and the director for the hospital, because we're in the way to open this Rescue for DCM clinic, which would be a rapid evaluation with a rapid access specialized clinic utilizing electrophysiology for degenerative cervical myelopathy. And that's going to be here at the outpatient clinic at the Lyndhurst Center. It's going to be an initial assessment and a longitudinal follow-up with these patients, with easy access and quick access for neuroimaging, and to send to neurosurgeons if it is needed. Hopefully, we're going to open this as soon as possible. I can still get referrals now if there's any case, because we have been seeing patients here. I can put in my other clinic, but when you have the clinic, we're going to actually get the patients there. And this is a clinic that I have the pleasure to actually have Dr. Carlos Ryan along with me in this clinic, and hopefully we're going to get more funding for her to have more time in the clinic that we can go work together, as she's a physical therapist with expertise in not only rehabilitation of patients with DCM, but also use of neuromodulation that you want to introduce for these patients as well. And there are many research studies that we can do, and we are doing now a dynamic imaging and physiological cardiovascular testing for people with mild DCM. We just completed C5 trial to see if neuromodulation using FES therapy with task-specific training can improve C5 pulse, which is then one of the main and serious consequences of this surgery for DCM. And was actually very exciting, the results, even though it was just a pilot study, showed the already significance of the therapy. And those are the cases that are persistent for 3 months. So they went through their natural history of getting better over 3 months. And if they don't get better, they will go to the trial and you continue physical therapy or conventional therapy, or actually do the neurotherapy, and they actually get better. And just saw a patient recently that he was so pleased because he fully recovered. We are also using Apple genotyping to try to predict the C5 pulse after surgery for DCM. And we are really hopeful that we can use the extracorporeal shock wave for pain in DCM, which is a main cause of the complaints of these patients, that nowadays we don't have much to offer in terms of treatment. So with that, I just want to leave to you some of the resources that you can have. So myelopathy.org is a good resource for clinicians, but also patients. And there is a series of podcasts on the 10 research topics that were highlighted by RECODE-DCM group that you can actually easily access through the QR code. So now I have time for questions before we go for the barbecue, which is the excitement for the day. Yep. Thank you.
Yeah. They said the surgical method influenced the outcome.
Try to repeat the question too, if you can.
Put it the up. I did send the message saying, please turn it off. And that's what we got back.
Yes. So the question is if the technique that is used interferes with the results. Yeah, so that's something that I go to meetings at Cervical Spinal Research Society meeting. I have these debates. I'm the one that is neurologist there among all spinal surgeons. You can put 10 spinal surgeons together. They're going to come with 20 different recommendations. If it's anterior or posterior combination, it's quite something remarkable, but not in general sense. The best one is always doing posterior. It's less invasive surgery. laminectomy can improve. And if the case is a case for that, typically would be anterior, the posterior decompression rather than anterior. Yeah, so the method interferes, as well as the experience based on the volume of the spinal surgeon as well. Great question. Any other questions?
Students and people in the audience, if you wanted to share some red flags that might make them come and talk to you.
Oh, okay. Yeah, so people that are, so yellow flags, I mean, is just yellow because of the color of the referee, because again, we're in the mood of the World Cup. But yeah, so those are things that we need to be alert. So if the patient brings a diagnosis and he already had a treatment and it's not getting better, it's getting worse, you need to ask yourself why it's getting worse. So I always teach my students and my residents, say, always ask the question, why? Why this patient is seeing you? Why the patient has this problem? Why is it getting worse since you had a proper treatment? So that's the first thing that we need to ask. So for that case, for example, I showed you was interesting because it was sent to me thinking that the neuropathic pain in the legs were because of the injury from the lower back. The patient actually had a polyneuropathy and was unfortunately a cause that was very severe, and there is no treatment. So that was the cause of the neuropathic pain. So ask always the question why. And some key things that we need to be aware is if it is not getting better after proper treatment for what the primary diagnosis was. And the other thing is if the patient, for example, is having falls, increasing falls, and you don't know why is that. So always check that in the cervical spine, because we tend to say, well, it's fall because sometimes people say, well, it's fall because it's getting old. I'm getting old. I don't fall. I may fall in the future. But the thing is, age cannot be blamed only. And you need to find a cause, and sometimes you find a cause. Can be a polyneuropathy, can be sometimes a degenerative cervical myelopathy, which sometimes is overlooked in many cases. But always ask, and you're going to capture this if you learn how to do a good neurologic examination in your life. You're gonna see that you can perceive those things in your neurologic examination. The last month, I made 3 diagnoses of DCM, and they came for TBI. So it's just a matter of examining and seeing what the symptoms are, and it fits with the primary diagnosis. And if it doesn't fit, or if the treatment that was for the primary diagnosis was successful, but the patient is still getting worse, always ask the question, why? And that is probably the red flag for you to think about. Yeah.
I mentioned falls. So when a fall happened, that is already a bad outcome. Fall can lead to many other very bad things. Yes. Weirdly, this week I was using my phone and I didn't even know this existed, but iPhones track now the quality of your walk from like in a symmetry perspective. And from that, they extrapolate the quality of your balance and so on. So how can you use these pre-fall things that are in our daily lives to help you to do your job and so on?
Yeah. I think that's an excellent question. We don't have nowadays any wearable device that has been validated, and I mean, you have this, but where is the point when you say this is pathological? We don't have that information. So you can get a watch and it's going to talk about your sleep apnea. And if you compare to polysonography, it's not even close in many cases. What I'm saying to you is you need to validate that too, even though you have nowadays. You need to validate and say, those are the features that can be a yellow flag or red flag for you to actually do MRI or seek medical attention. And I think that's the point that we don't have information and we need to get more information. So I'm excited about this clinic that I just shared with you because it's the first one that I'm aware in Canada. We know many clinicians are doing their great job, like many spine surgeons looking after these patients, sometimes family doctors, they are doing great job, but we don't have a specialized clinic. And what the specialized clinic brings up is people to work together and sorted out this kind of great research questions that you just made. We are just having a meeting before here. We are talking about exactly like this, what you can use as a wearable device to track these patients to see if they are at higher risk of falls, and what is the pattern that would say, oh, this patient needs to have MRI of the cervical spine. So that's a great research question. We don't have an answer, We have the devices, we have the information, but we don't know how to use the information so far. Any other questions?
I had a question.
Yeah, sure.
Oh, you have one? Oh,
Okay.
the coach.
Chat says, in the worst surgical outcome slide, does a surgical approach have any effect on the outcome? For example, posterior approaches versus anterior ones in outcome. Does IONM improve surgical outcome in DCM? A recent SRMA reports a high specificity and low sensitivity in SSEP and higher effectiveness in multimodal IONMS. But how exactly are these results clinically meaningful? How long for any clinically meaningful follow-ups?
If you understood the question is if you do the surgical treatment, if it's going to be how you can certainly say that was a good work to be done is the question, I think. Because typically what you follow is clinically, and they typically do MRI after the surgery. So we don't use, I like neurophysiology. I'm a big fan. I work with this in my clinical practice, but there are limitations. So we can't rely on neurophysiology for that. So I'm not sure if you can rely that. You can make that the point that you may use as a accelerated outcome measure, but it is not available everywhere, and you need to have actually good expertise. And if you have patients that are prone to have sleep apnea and you try to do SSP, good luck. You can't keep them awake, interferes with your results, and it becomes a very challenging thing, I can tell you. Because once you put them to do and you need to cover their eyes and keep silent and no other stimuli, they tend to fall asleep. And that's why you have a drop in their results as well. So it becomes a challenging as well, even though we still use, but you need to be aware of some limitations. I mean, I hope that's the question that was, they can email me if they want the question particularly, but if you understood the question was that, hopefully, yes. Yeah, sorry, you're going to ask a question.
Yeah, it was just, you talked a lot of how manual manipulation doesn't work, but at the end of your presentation, you talked about that, I think at a pilot clinical trial, C5 or something, you seem really excited about the results. If you could tell us a bit more of that trial.
Yeah. So the C5,
excited.
yeah, exactly. So the C5 trial was a pilot trial that we did actually patients that they had diagnosed of moderate severe DCM, they went for surgery. When they came back, we know the literature is between 1 and 29% would have C5 pulse, which gives proximal weakness. Typically, we know based on the tests that they do here is more than C5, it typically extends C6, sometimes C7. And that's basically what the nerve roots are injured, or there is neuropraxia, which means there is a period of dysfunction of the nerve root. So more manipulation caused that. But basically, the best hand surgeons' hands, you're probably going to get like 5%. Still quite prevalent. So what they did, they typically go send you do exercise, home-based exercise, physical therapy to get better, and you want to prevent frozen shoulders. So when I prevented that patient, it doesn't work with the shoulder because then after a while you get arthrosis and that is game over. There is no other way to treat. So, but we saw these patients after 3 months, typically. And they were the ones that we know at least 130 would recover fully within 3 months, and the other 130 probably is on the way already. We want to get the ones that don't recover. So we got this case from the surgeons. People are desperate, meaning the surgeons and the patients, because they want to get it better. So we actually randomized into 30 sessions of physical therapy for the shoulder and for the arm, and 30 sessions of functional stimulation with task-specific training, plus the physical therapy. So was that way that we did. And we saw that treatment group actually got much better. So for that, it is quite well established that is an ambulatory therapy for spinal cord injury, stroke, and all. And for this, which is a model of a lower motor neuron injury, worked very well as well. So that was encouraging to see.
Yeah, it's exciting.
Yeah.
Okay, let's thank Dr. Furlan again.
Thank you.
Okay, so now everyone could go outside.